It's great to have you join us again for another episode of Conversations and Connections, where we are creating women leaders for life. Thanks to our sponsor, Ogilvy Health, for supporting HBA this year. When healthcare impact is your goal, let Ogilvy Health be your partner. Welcome to our special two-part series in honor of Lung Cancer Awareness Month, where we are celebrating trailblazing women who are making waves in Canadian lung cancer care, research, and advocacy. We're thrilled to have Dr. Rosalyn Juergens and Dr. Michela Febbraro with us today, two exceptional oncologists whose dedication, expertise, and innovative spirit are transforming the landscape of oncology care across Canada. Dr. Rosalyn Juergens is a renowned medical oncologist and accomplished clinical researcher who brings a wealth of experience in lung and esophageal cancer. She earned her medical degree from Georgetown University in DC, completed her internal medicine training and medical oncology fellowship at Johns Hopkins Medical Institute, and she holds a PhD in clinical investigation from the Johns Hopkins Bloomberg School of Public Health. Alongside her impressive academic credentials, Dr. Juergens serves as a strong advocate through her role as current president of Lung Cancer Canada, and she leads influential research initiatives as the chair of the Lung Disease Site Team and head of clinical trials at the Juravinski Cancer Centre in Hamilton, Ontario. She's known for her bold vision, her commitment to advancing patient care, and her passion for empowering women in medicine. Also joining us today is Dr. Michela Febbraro, who is a medical oncologist at the Sault Area Hospital, where she brings her expertise and deep commitment to patient care to her hometown of Sault Ste. Marie, Ontario, commonly known by many as the Sault. She completed her undergraduate studies at the University of Ottawa, her internal medicine residency at the Thunder Bay Nosum University campus, and her specialty in medical oncology at McMaster University, as well as a master's in health research methodology and a fellowship in lung cancer. Dr. Febbraro is passionate about holistic cancer care and is dedicated to serving her Northern Ontario community. She is a powerhouse and a rising talent poised to make an impact. This episode delves into their career journeys, what inspired their focus on lung cancer, and how authenticity and mentorship have shaped their leadership in Canadian oncology. You'll hear about their unique perspectives and the pivotal role that mentorship has played in building networks and fostering innovation for women in medicine. Tune in for an engaging conversation with honest reflections, practical advice, and the stories that are driving meaningful change in Canadian cancer care. Good morning, ladies, and happy Friday.
Good morning.
Thanks for making the time. Look, November is Lung Cancer Awareness Month, and we are honored to be joined today by some of the most inspiring women who are leading the way in lung cancer across Canada. So we like to start off at Conversations and Connections. We like to start off with learning a little bit more about our guests. And we ask everyone, we all have superpowers. What is yours? Dr. Febbraro, we're going to start with you.
My superpower.
Yes.
Oh my goodness. My husband affectionately tells me that I'm anxiety girl, and I just jump straight to anxious at every leap and bound. So I think that would be my superpower, but to spin that into a positive, it makes me extra organized. It makes me feel like I'm in control, because if I'm worried about something, it allows me to prepare for it a little bit more. So that's my superpower, I would say.
I love that. Thank you. That's good. Dr. Juergens.
If I have a superpower, so I love public speaking. It's one of my favorite things to do. And as part of being an oncologist and doing public speaking, I get the honor of having to enunciate really crazy long pharmaceutical names. And I feel like that is my superpower, is that I can manage to throw out all these different drug names pretty much without batting an eyelash. So that if I have a superpower, it's my skill set of enunciation that has allowed me to say all these weird words when I have to bid up in front of people.
You are an excellent public speaker. I've seen you speak on many occasions, and you're clearly very comfortable in this space. So pleasure to have you both here today. And to start off with, can you share maybe a bit about yourselves and how you became involved in oncology? And I guess what inspired you to focus on lung cancer in particular? So we'll go back to Dr. Juergens and give Dr. Febbraro a time to think.
Sure. So, this was a path that I didn't realize I was going to tread. I knew from an early age that I wanted to become a doctor. It was a very focused path, and I didn't deviate from it. But not that different from Dr. Febbraro. I originally thought that I wanted to go back and serve my home community, and what I knew of my home community was family physicians. And so I went to medical school thinking I wanted to become a family physician. I liked the whole person care that came with being a family doctor. And so that's where I thought my destiny was going to be. And then I went to med school, and they force you to try all sorts of different rotations in med school. And one of the rotations I got put on was called hematology. I was thoroughly irritated that I got sent on this rotation because in my mind, it was a very small aspect of what went on. And I'm like, how is this truly going to prepare me to do clinics and things like that? I just didn't have the vision for what that was going to provide me. And so I showed up to this clinic and I had one of the most incredible days of my life. I got to hang out with it was actually a community oncologist, and we got to see patients with all sorts of different cancers. But I got to see some of the science behind the oncology care, and that's really what hooked me, is there was all of a sudden this move in oncology just as I was getting in, where we were understanding the molecular biology of cancers and targeting cancers with directed drugs. But what was cool is we had all this science, but yet they still were providing whole person care. So I felt like I had met my perfect profession, where I can provide whole person care, but yet I can still geek out on all the science. And so I ended up changing paths and became a medical oncologist. With regards to how I chose lung cancer, I wish I could tell you it was more inspired. When I started going through the different rotations and I was trying to figure out where the right fit was going to be, and to be honest, it was, you're a woman, you should do breast cancer. And I just didn't find the space as appealing, and so kept looking. And eventually I landed myself with someone who was like me. Her name was Dr. Julie Bramer. Julie is a medical oncologist at Johns Hopkins. She and I both grew up in the Midwest of the United States. She and I literally grew up about 2 hours from each other. Her brother now plays, or I think, no, her nephew now plays football for Iowa State. And so I get to see all sorts of posts from home as she goes to football games. And she was a lung cancer doctor. And so when I started to hang out with her, I saw characteristics that were similar to me. She partnered me with a guy named Dr. Charlie Rudin, who's an expert in translational research in small cell. And so I created sort of this mentorship, set of parents, right? Who sang to a couple different parts of my soul. So that was how I ended up in lung cancer. And when I sit and think about it, the patients are just incredibly gracious and thankful for the care. And my gosh, lung cancer sure had a long way to go when I was first starting. Not that we don't still have a long way to go now, but I just really felt it was a space where I could really make a difference. And so that's how I landed here.
I want to talk more about your mentors after. All right. I'm switching. I know you're both doctors and very accomplished, but I love your first name, so I'm switching. Michela, go ahead. Yeah, what about you? Sure. Tell us about you.
So I knew from an early age that a career in medicine was something that I was hoping to accomplish, whether that be as an actual physician or drug design and development. When I was in undergrad, I had a keen interest in organic chemistry and how drug synthesis interplayed with biochemistry. And so leading into medical school, I was actually backing up with a master's degree in organic chemistry that sort of bridged drug design with how it interacts in the human body. And lo and behold, I got into medicine first, so I went down that path. And I always wanted to come back to Northern Ontario, which is where I practice. And similar to Roz, there's a lot of family physicians here. There are a lot of subspecialists, but when you're training through the Northern Ontario School of Medicine, a lot of what you get exposed to first is primary care and family medicine. And what I liked about family medicine was that longitudinal aspect of care, that cradle to grave mentality. I really liked being a part of somebody's journey and a meaningful part of somebody's journey. And I liked the patient connection and the patient relationships. So when I was looking at what career I wanted to end up in, family medicine was actually what was fitting the bill. And then I got into just wanting to learn more. There was something about internal medicine that just, the science was always changing. There was always something new. The patients were sick. They were complex. And I ended up choosing a internal medicine path for my training after medical school. But I was finding that with that internal medicine pathway, I was missing that longitudinal aspect of the patient journey. And in comes oncology, and we can get into some of the facts as to why I really tried not to like oncology, but in comes oncology, where I found I was getting some really great science, I was getting some really great learning, but I was also getting that longitudinal aspect to the patient journey and fostering those patient connections, which I really do appreciate and thrive off of. It fulfills me in my day-to-day. And so I ended up choosing oncology. When it comes to why lung cancer, it really, plainly put, actually comes down to Roz. When I was choosing medical oncology, I was coming from a very small internal medicine program. And the thought of leaving that comfort was very scary. And part of your process of choosing what program to go to is you have to go away and do electives at all of these institutions. And as luck would have it, I got placed with Roz for 4 weeks. And she was just amazing. I appreciated the fact that she taught me the science, and she had great relationships with her patients, but she also really cared about who I was as a person. I don't know if you remember these things, Roz, but like after we would sit in clinic or have a full clinic day, we would talk through what I learned, but then I was also planning my wedding at the time. So then she wanted to have conversations about, so what are we doing next for wedding planning? And, just really interested in, who I was as a person. And that made me want to come to McMaster University. And the first thing I did when I got there was I reached out to Roz and asked if I could be have a longitudinal clinic with her, and she said yes. So that's how I got into lung cancer, and I've never looked back since. I'm very thankful for it.
Well, that is an awesome story. We're gonna talk more about that because that is awesome. Working in the lung space, I can say that the medical oncologists and the allied health teams are incredible, and you two are clearly that as well. So. Very interesting. I learned something about you both that I didn't know. Look, so your passion really comes through, no doubt, on, I can't believe you've known this for so long, that you've wanted to be physicians. That's amazing that you followed your path. And I love the blog on Lung Cancer Canada's website, the President's Corner or the President's Newsletter. I love that, Roz. You recently said there, I'm going to read it out, more Canadians are living longer, fuller lives with lung cancer than ever before. These are breakthroughs worth celebrating. But let us be clear, progress has not been reached by everyone. So let's talk about Lung Cancer Canada and the power info. It's such an impressive organization, but let's talk about the powerful impact that it's having to drive change for patients. So for the folks on the line who, for our listeners who might not be familiar, what is Lung Cancer Canada, and what are some of the key ways that it supports patients, caregivers, healthcare professionals, and the general public, really?
Yeah, so Lung Cancer Canada is the national organization that has been put together to help support people who were affected by lung cancer, whether it's patients, their caregivers, et cetera. And we're here on multiple fronts. Really, the organization started out from a space of unmet need. There was a need for educational materials. There was a need for support that didn't necessarily exist in other venues. And so that's where we really began, was trying to be that voice on the other side of the ether for folks who were struggling with, their lung cancer journey. And lung cancer hasn't gotten as much attention as some of the other cancers that are out there. And part of that is there hadn't been as many lung cancer survivors to have a voice. That's changing now, which is fantastic. But we really saw an unmet need there, and so that's where Lung Cancer Canada began. If we look at where we are now, we have all sorts of functions. That core function, though, is preserved. We're a space where if you're a lung cancer patient or a family member looking for help to try to navigate the system, we're there to take those phone calls. We have a support program with a social worker who can help with some aspects of what's going on with folks. We've got a website that has all sorts of educational materials. There's a group of us who get together and we write a book that basically is a guide to lung cancer, and it's free on the website. We've got it in English and French, and we're working on getting it translated into other languages as well. But it's a safe space for educational materials for patients who are faced with lung cancer. So that's one aspect of what we do, and we actually have different aspects of support. Like we've got Kayla's Angel Fund for folks who are struggling financially, trying to help get themselves through. There's lots of different things that we have to offer from that perspective. On the flip side, then, there's a group of very dedicated physicians who form something called the Medical Advisory Committee. So the Medical Advisory Committee does all sorts of different things. These are all volunteers. So these are physicians who work in the lung cancer space across the country. We've got representation from, I do believe, every province. And again, we work on those educational materials. We hold patient summits across the country, so people locally can meet other people who are going through lung cancer. And we've got national support groups, and then we do local supports as well. But then we also, on the flip side, try to help advocate for access. So one of the reasons I found myself in a space of advocacy, and I didn't anticipate that this was something that was going to be part of my journey. I'd come from the U.S. I was born and raised in the United States, and then came to Canada. I married a Canadian. Up to Canada I came. I've been here 15 years now. I actually just became a citizen a couple of days ago. But I realized that there were some really wonderful aspects of Canadian healthcare, but there were definitely spaces where we could improve. And one of the areas of improvement that I saw is, trying to get quicker access to novel therapies or novel technologies, as it may be that relates to the journey of a lung cancer patient. So the Medical Advisory Committee actually gathers information whenever there's a new drug that's being looked at for approval and funding in Canada. And I think we as a national group actually have never missed a submission for a new drug to provide insight on what the impact is for Canadian patients. We take all of these new therapies that are being developed across the planet and boil it down to what does this mean in the Canadian context, and how will this impact patients across this country? And we've been quite successful at helping support new drugs get through the system as quickly as possible. But not only new drugs, we've been working on advocating for molecular testing. One of the things that has really improved our ability to do what we do is we've realized that lung cancer isn't just one big brother disease. It's actually a whole bunch of, honestly, rare diseases that are subtypes of lung cancer. And I can't treat somebody to the best of my ability unless I understand the underpinnings of what's going on with their cancer, not to mention the underpinnings of what's going on with the patient. But we've now advocated and written letters and helped support getting access to something called next generation sequencing, and that's now available across all the provinces. And then the more recent thing that we've been working on is trying to get access to test to try to identify cancers at an earlier stage. And so that's something called screening. Most folks are familiar with screening for breast cancer with mammograms, or for cervical cancer with pap smears, or colon cancer with either something called FIT tests, where we test your stool for blood, or if we do scopes with like colonoscopies. Lung cancer screening has been a thing since 2010. The original paper that showed that lung cancer screening improved outcomes was in the New England Journal, I do believe, in 2011. And it's the only screening test that not only improves your chances of surviving lung cancer, so it reduces lung cancer related deaths, but it actually just improves your chances of survival in general. So no other screening test can actually say that. We improve overall survival as well as lung cancer specific survival. But it's a complicated test to get implemented. And so we've been helping to support and advocate trying to get lung cancer screening available across the board. And we've had successful supports of pilots across the country. And now we're seeing a more robust access to screening. We're still not there yet, but it's work that we continue to do. So these are just some of the aspects of things that we do as an organization.
Well, I'm so impressed with this organization. I really am. I've only been working in the lung cancer space for a year and a half or so, a couple of years, but I'm so impressed. I formerly worked in the breast space, and I can say you are on par, your team is on par, and you're going to make great things happen. And so I hope to help rally people by virtue of this conversation. Michela, the next couple of questions are going to be related to Ros and Lung Cancer Canada, but by all means, jump in if you have something to say, okay? So before I ask this next question, I just have to say, how cool is it that the current president and the most, I think Dr. Stephanie Snow refers to herself as the immediate past president,
Yep.
right, of Lung Cancer Canada are women. I think that is just awesome. And so an obvious question on a female empowerment podcast would be, how does Lung Cancer Canada support women in leadership roles? What has your experience been today? And what changes have you noticed in the recent years regarding women's representation within Lung Cancer Canada?
Yeah, so honestly, if you look at lung cancer in general, we have historically had some incredibly strong women that are out there. When I think back to, again, that first mentorship experience with Julie Bramer, she actually then introduced me to the network of women in thoracic oncology. So I got to see some of the powerful women who were moving things forward. And I still remember meeting Joan Schiller, and Michela will know Joan Schiller because she was the first author on the paper that, basically taught us about platinum doublet chemotherapy back in the day. And I just remember being starstruck meeting her. And then, next thing you do, you get to meet a Canadian icon, Frances Shepherd. And Frances Shepherd has been responsible for incredible improvements in drug development over the years. And so she's an absolute icon. And then she mentored a woman called Natasha Lale. And Natasha Lale was the original president of Lung Cancer Canada. She was the first president of Lung Cancer Canada. So the organization started off with a woman.
I did not know that. Really?
Yeah.
Okay. Wow. Okay.
She had partners in crime, though. This isn't all about the girls. This is all about lung cancer, right? And so there was many people who were involved in those very early days. And that's the one thing about Lung Cancer Canada is you may evolve through different roles and opportunities. But it's funny, in other roles that I've played, you play your parts and then you move on and you do other things. And that's the one thing with Lung Cancer Canada is, it's just so important to us to try to see that we move the needle forward, that even when people don't have a formal role any longer, they continue to provide the same level of input. And, I would be remiss if I didn't mention the person who really got me involved with Lung Cancer Canada, which is Paul Wheatley Price. So he's the past.
He's so awesome. Yes,
yeah.
yes, yeah.
And it's one of those things where I had peripherally become involved with the organization. I had joined as a member of the medical advisory committee, and he was about to be taking over for Dr. Lael as president. And I was still relatively new in the Canadian space. But he and I knew each other from various and sundry things, and he tapped me on the shoulder. He always teases that he bought me a glass of wine, and that's what convinced me to take on the medical advisory chair role. And he and I had a very real conversation, right? Going back to, how are you going to make all this get done? At that space, I had 2 young children at home. I had just taken over as, I had been the head of the lung cancer group at McMaster there for a couple of years, and I had just agreed to take on the role of the head of our clinical trials unit. So I was already taking on a few different leadership aspects of things. And so this was one more ask. And I was like, Paul, I'm not sure how I'm going to balance this all. And he's like, Roz, at the end of the day, we're looking for your passion, but the beauty of the lung cancer community is that it's a community, and many hands make light work. And so that has always been the case. So if we look back to just last year alone, I think we had over 15 new drugs that were being brought forth through INES and the Canadian Drug Agency for approval. So people have no line of sight on this, but we put together a physician submission for each of these new drugs that are developed. And the paperwork alone, the effort that goes in from our part to write one of these is multiple hours. So we sit down and we gather data on quality of life and symptoms and, again, impact and Canadian context. And we gather all sorts of information to try to help the decision makers really get a sense of what is the impact going to be here in Canada. And we take that role very seriously. But the beauty of it is there were so many of us who were so invested in this that we were able to distribute the work across, again, dozens of physicians. So no one person felt burdened. And all my role is just to make sure that I had all the pieces moving. And it's not hard when you have people who also see the same vision, right? When you have a single vision where we're all just here to try to make the life of lung cancer patients better, then it works pretty easily. But if you look at how does Lung Cancer Canada manage with different aspects of what I do, I've been part of one of our fundraisers every year called the Evening of Hope. It's always in November. November's a tricky time for me. I tend to go home to visit my family. We actually every other year celebrate Christmas over U.S. Thanksgiving, which happens in the month of November. My daughter was born in November. So you know what? They've made it possible for me to video in from the farm in Iowa to be able to participate in some of these activities. This year's Evening of Hope is my daughter's 13th birthday. Guess what? The family's all going. We're going to celebrate her birthday and have a little sleepover with some of her little besties on the Saturday night, and then we're gonna go as a family because my kids see that this is something that is passionate for mom, and they appreciate that mom gives time when they need it. And so, when it's my daughter's softball games or my son's volleyball games, I do everything in my power to get there. So when I'm mom, I'm mom. And when I'm advocate, I'm advocate. And when I'm doctor, I try to be doctor, and I try to be my best self whenever I'm doing each of these things. And I just have to pivot here and there, and, we make it work. I'm going to the Canadian Cancer Research Conference. We're announcing something incredible. It's an action plan trying to really get us all together as a Canadian community of basic scientists, translational scientists, clinicians, really trying to move the bar forward for lung cancer. And that action plan is going to be announced in a few days. I'm heading out, but it's after Halloween because my daughter, is a grade 8, and I want to see her and her girlfriends go out and trick or treat, realizing that there's only so many more opportunities for some of these things to be had. So I'm doing that. I will then deal with some work stuff for a day or two, and then I'll be back so that I can see playoff volleyball for my son. So we make it all work.
This is something that I've been wondering, because I know you are an extremely busy woman. We're all busy, but you take the cake on this one. You are very busy. And as a mom also of teen girls, yes, I wonder how you shift and how you create time. So that's really great to hear. Okay, we're going to shift lens for now, and we're going to dive into gender disparities when it comes to lung cancer. And so I think, Michela, this one's going to be for you. So what unique challenges, I know in certain types of tumor sites, solid tumor sites, there are some things that are more relevant to women, or not trends, it's not a great word, but there are things that are more relevant to women. What unique sort of challenges do you think that women face in lung cancer, either be it research or diagnosis or care? And how do you think we can work to bridge those gaps?
That's a great question. I think when it comes to lung cancer, I think we need to take a step back away from women first and just talk through sometimes the stigma that's associated with lung cancer. And lung cancer is strongly affiliated with a history of smoking, but there is an increase in the diagnosis of lung cancer in people that have never smoked. And so when it comes to that population, the patients that do not have a smoking history, they're almost faced with a tougher journey sometimes, because lung cancer doesn't come to the forefront. And often, and Roz can correct me if I'm wrong, but often these individuals are women. And so when it comes to the diagnostic process of a female who has never smoked, that diagnostic process can actually be protracted. It can take a long time because your first thought is, well, maybe it's a pneumonia or maybe it's asthma. Often these women are also younger. And so we're talking women under the age of 65, which means that they haven't reached that retirement nest egg. They're still on that upper track of developing themselves in their careers, developing themselves in their families, in their homes. And so then you're having to deal with the social aspect of these women, trying to make themselves personally successful and then being hindered by a diagnosis of cancer. So those are, I think, the big things when it comes to cancer, when it comes to women in cancer. There's a lot of great literature, and there's a lot more education that's coming out in diagnostic testing and in getting these people through the door with their lung cancer diagnosis faster. And Roz sort of touched on that in terms of screening. That tends to hit the people that have a history of smoking, but even just the grassroots efforts in communities to just educate primary care providers about, a pneumonia that doesn't go away after 2 months may not be a pneumonia. It might be something else, and we need to start thinking through cancer, even if you don't have a history of smoking, is really important. And that's being spearheaded through Lung Cancer Canada. The initiatives of Lung Cancer Canada to educate patients to advocate for themselves. The government pushes to, take hold of your health and your journey. Doesn't get lost in the messaging for patients. And I'm seeing so many more men and women. Often the men is because of the push from their partners, their female partners, but so many men and women getting diagnosed earlier because they were like, no, something just wasn't right, and the healthcare community is listening to that.
We're doing some educational activities trying to help support family physicians, right? Like that is an all but impossible job, right? And, when somebody comes through the door with a cough, of course you're going to think, post-nasal drip, acid reflux, post-viral cough. There's lots of different things. And the majority of the time, that's what it's going to be. But Michela's right. If something isn't going away with basic things, then we got to start thinking outside the box. The statistic that I state that I think shocks people is that more Canadian women will die of lung cancer than will die of breast cancer, ovarian cancer, and cervical cancer combined. People
no.
Absolutely.
Really?
Absolutely.
Oh. Wow. Okay.
People just have no concept that lung cancer is this common. And so it is the most commonly diagnosed because we recognize that all you need to get lung cancer is a pair of lungs, and we are all born with them. And so, it is something that, lung cancer is common. Unfortunately, dying of lung cancer is still too often the eventual outcome of this. And so when people think of women's health, lung cancer doesn't even bubble up anywhere near the top of the list. But, there are so many things that factor into a diagnosis of lung cancer, right? And we're not there yet. We don't have genes that we can test that say you're going to be higher risk for lung cancer like they are in breast cancer. We don't have the same, family history that can clue us in to looking for lung cancer early like they do, again, in colon cancer, breast cancer. There's people who will smoke every day, from their early 10s, and never get lung cancer. And then, if you look at the most common type of lung cancer, something called adenocarcinoma, we're now getting to the point where literally 1 in 4 of them are people who've never smoked a cigarette. So there are other factors that are at play here. And it may be genetic factors. It may be environmental exposures. We're now getting more and more literature about air quality and how that can impact your risk of getting lung cancer in your lifetime. Radon exposure. We live in the north, right? Like our houses are on top of bedrock, and different gases don't move quite the same way. And so a lot of us have basements and things like that in Canada. And so those are risks that exist. But we don't understand how all the dots get connected just yet. And so, I've been going around telling folks, be mindful of your lungs. My mom would crack up if she knew that I was saying this, but like my mom, since I was a little kid, and my mom's a nurse, but very protective of our lungs. Again, we grew up on a farm. There's lots of different exposures out there. And we painted fences when we were a kid with masks on, right? Because she didn't want us breathing in the fumes. Never got to go outside if there was crops being sprayed or things like that. She was like, you know what? We just don't know when we're going to protect ourselves. And, I grew up, I'll date myself here, right? But I was a big hair girl back in the day. My bangs stood up to here, and, there was definitely some Aquanet that existed in my household. And I'm not even kidding. My mom, she wouldn't let us have aerosols like that in the house unless she actually taught us that, if you're going to spray your hair, you take a deep breath, you spray, and then you get out of Dodge. Because she didn't want us breathing in all this stuff, right? And who knew that maybe some of those little things poked into how I ended up becoming a lung cancer doc and somebody who, wants to help people protect their lungs. But when we don't know what series of events is going to lead to things, you got to protect the things that you just can't readily replace, right? And lungs are not something that you can readily replace.
As a daughter of a nurse, I hear you. I feel you, okay? Totally get it. And she's the reason why for many decades I have loved nurses and will do anything to help support them because of her importance that she sort of instilled on me, the importance of nursing. Okay, so look, let's talk about research a bit. Are women appropriately represented in research? I mean, research, there's such a body of and wealth of research, but it's hard to sort of comment on that generally. Is there a place where you think, women could be empowered or encouraged to take on more of leadership roles in research? It seems like they're doing a pretty good job. When I look at some of the trials, the clinical trials that I see, it's equally represented. But what about patients? Are patients equally represented? What do either of you have to say, comment about that?
I think in the lung field, in terms of leadership and research, there are so many amazing female physician mentors that are out there across Canada, and even internationally, that, to be fair, it's never even, and how cool is this too, but it's never even come across my mind that, oh, I'm a female, I probably shouldn't do this, or I probably should be nervous about doing this. That has never come across my mind when it's come to lung cancer leadership in Canada, and even just the idea of doing research, which is really, really cool and is so incredibly special as a young female physician just starting out. For patients, we do try to have equal representation of men and women on trials, on clinical trials, but sometimes, depending on the subtype of lung cancer, men may be more likely to be diagnosed, and so they may get a bit more representation, and that's not necessarily because there's anything wrong with females getting, or any additional hardship for females to get onto this trial. But it just has to do with how likely is a male versus a female to be diagnosed. But we do, I think, a lot of trials do try to have equal representation of men and women. The other thing that that happens in a lot of the lung clinical trials is Asian versus non-Asian as well, because there are different aspects to cancer that affect the Asian population versus the non-Asian population, and so that's something else that we try to have equally represented on clinical trials.
The one thing I'm gonna actually bop the ball right back to Dr. Febbraro here in a split second. One thing that we've recognized with clinical trials is there are so many factors that go into why somebody decides to do a clinical trial, right? And part of it is knowledge about the trials, and then access to trials, et cetera. And I could imagine a world in which, again, women play a unique place in the household, and that is part of that stigma of lung cancer is lung cancer patients are often reticent to ask for help. There is often an internal, thought of, especially for folks who smoked, right? I brought this upon myself, so therefore I should never ask for help because this is my fault. And that is absolutely not the case. No one deserves to get lung cancer. It's awful, that we live in a world where we've got incredibly addictive cigarettes and all these types of things that get to people when they're at a young age. But when we think about access to trials, lung cancer, often, not always, but often patients are older. Often patients have more other medical illnesses associated with it, which makes it harder for trials. And so one thing that the lung cancer community has been good about is binding together. So I mentioned, Frances Shepard. She was instrumental in bringing together the original groups of people who did research on chemotherapy after surgery, so trying to increase the rate of cure of our early stage lung cancer patients. And it was really through the work of the LACE meta-analysis that showed that we actually improve outcomes of lung cancer patients by giving post-operative therapy. But that effort really took everybody leaving their egos to the side and saying, yes, we're going to bring this information together. We're going to collaborate together to look at the benefit. Because it's harder to get 10,000 lung cancer patients onto a trial because of these various and sundry issues. One of the other issues, though, with clinical trials is, there's a lot going on in these people's lives, right? And for some, their outcomes could be short. And so when you're looking at someone telling you you've got a life-limiting illness, and we're talking in sometimes months to parts of years of time, you have to stop and think, how do I want to spend that time? And so sometimes volunteering for a clinical trial may not be your top priority. And so one thing that I think is incredibly important is that we need to make it as easy as possible for patients to be able to participate, so they can have, their cake and eat it too. They can still preserve, home life and still be able to access the research. So Michela actually stayed with me not just for the medical oncology part, but she actually did a master's. And her master's work is looking at how do we set up the infrastructure within physicians to make that more possible. So I'm going to let Michela quickly just talk a little bit about some of the work that she has done that's laying the groundwork for how do we make clinical trials more accessible.
Thanks, Ross. This wasn't even a planted push.
And it perfectly tees up to one of my other questions, so perfect.
Wonderful. No, a lot of research when it comes to clinical trial access looks at things like distance from cancer center or patient factors or institutional factors. But one of the pieces of literature that we found was lacking was the clinician factors and what parts do clinicians play when it comes to access to a clinical trial. Because at the end of the day, a patient can want a clinical trial, they can get access to it, but some patients don't even know, and if they're not offered or they're not sent to a center that has a clinical trial, then they may not ever get the opportunity. And so my research was looking into those aspects of physician preparedness to practice clinical trials upon graduation of medical oncology training. And what we found is that students, residents, and fellows were all very willing and wanting to have their patients partake in clinical trials. They understood the importance of a clinical trial and to our patients and to the lung cancer or the cancer community as a whole. But they lacked the knowledge or expertise on feeling confident or competent to get their patients to a clinical trial, whether it be, learning how to onboard a patient or to bring a clinical trial to their institution, whether it be looking at how to be a principal investigator or a sub-investigator on a clinical trial in their own community. And so what we found through this research is that we need to increase learner training in clinical trials and increase their exposure. And since that research, Roz, at least at McMaster, has developed a clinical trials rotation where residents and fellows can actually, learn those procedures. They get to work with the clinical trials department. They get to actually partake in clinical trials as fellows. And so it's that idea that if you take that baby step while you're training and under the security and safety net of a preceptor, then once you're doing it by yourself for the first time as a staff, you might not be an expert, but you have some knowledge which will make you more comfortable. And I know for myself, that was probably instrumental. I mean, I came to my community and it was literally day 2, I think I was texting Roz being like, they've asked me to take on the lung portfolio. And she's just like, you've got this, you've done 2 years of this with me. If you have any questions, just let me know. And thankfully, we do have a really great support network at my institution to support me in this. But it was something that I don't think I would have been as comfortable taking on had it not been for that exposure. So that's what the research was looking at, and we're hoping to improve that exposure for our trainees.
That's super interesting. Did not know about that about you, Michela. That research. That's wow. Would you say that this is more common or less common, this kind of program that Roz has set up across?
We're the first one in the country. So
yeah, you gals need to talk more about that more publicly about that. Wow, that's awesome.
If we look at things, right, like cancer care we want to deliver closer to home, right? And a patient's not going to be able to get access to a clinical trial in their home neighborhood if the physician has never had exposure. And oncology is different from most other, especially internal medicine subspecialties. I remember this when Michela and I were working on getting this work published, and they were like, why does community need access to research? That doesn't happen in some of the other subspecialties. And we're like, it is critically important. If we're going to get representation, then the only way to do that is to have the trial offered closer to home. And there's been incredible work done through a group called the Triple CTN. Janet Dancy, another great physician leader, heads that group. And they have been building something called the CRAFT model, which is looking at, how do you allow a site like Princess Margaret or Hamilton or BC Cancer or whatever it might be the hub for the regulatory aspects of things, where we've got lots of experience in that, and then have spokes where the care can be delivered closer to home and then help support that care through those hub and spoke links. And I think that that's going to be incredibly impactful in a country as big as ours. We don't want people to only have access to clinical trials if they live in the GTA or the Greater Vancouver area or in and around Montreal, right? It shouldn't just be urban folks who get access. That then makes it such that we're not actually representing the true lung cancer community. And it's only through efforts like this that it's going to help.
And just to piggyback on that CRAFT remote access framework, it's being done in Northern Ontario right now with Dr. Lacey Petrie leading the way in Sudbury. So Sudbury right now has the very first remote access clinical trial being offered between Sudbury, Timmins, and then Sault Ste. Marie is the counterpart where I am here. And so we are offering a clinical trial remotely for patients out of Timmins, specifically in lung cancer. And this was all through Dr. Lacey Petrie taking that remote access framework and putting it into action for Northern Ontario patients.
Another powerful woman, I will say.
I thought maybe she might come up because, look, having grown up in a rural environment in Atlantic Canada and now living in Ontario, look, there's a place clearly for academia, but community, I feel, sometimes doesn't get the attention it deserves. And you know who taught me about community oncology is Sudbury and the Sioux. The folks, the great teams there. So I'm glad that you brought her up. I was going to ask about innovative projects or collaborations, but it sounds like you just completely got Michela to share that. I don't know if there's any other projects that you want to spotlight that come top of mind before we head into mentorship, if not, or female disruptors doing crazy things to make change. Anybody come top of mind?
I think, one of the things that is coming to mind is the Canadian Cancer Trials Group is looking at how to improve access to clinical trials for many different disease sites. I believe one of their head and neck clinical trials right now also has some sort of remote access aspect to one of their clinical trials as well. So this is something that we're seeing across Canada in not just one disease site, which is really special. And it's wonderful that the Canadian Clinical Trials Group is looking at ways that we can improve access for our rural remote patients across Canada.
And you have certainly leading that charge. I loved your podcast with your fellow colleague in the Sioux on Lung Cancer Canada's podcast. And it really was so helpful. And if ever anybody is trying to learn about community oncology, I always just say, just go listen to this podcast. It will help you. It's an hour well spent, and it will inform and enlighten you.